Hey guys, my name is Russell Linville. I'm a physical therapist here at Training House, and this is the shoulder complex. And we'll be going over today. We'll get into the objectives and things like that to talk about the shoulder. Give you the basic overview here of anatomy, kinesiology, musculature, ligaments, neurovascular structures, etc. So, as part of your education, undergraduate education, I'm sure you've gone over some of this. This will be a nice refresher, as well as dive a little deeper maybe into the kinesiology of the shoulder complex. And again, this is meant to be a lunch and learn. It's supposed to be a basic education program for you with your time at Training House here. So the overview and objectives here, the purpose of this is to provide basic concepts and information to the current and past interns of Training House in order to facilitate and improve athlete management and care. The goals here are to understand the basic anatomy of the shoulder joint and describe the concept of both arthro and osteokinematics. So what is the basic anatomy of the shoulder complex? Well, here we have some of the Boney Anatomy, which we'll be going over. On the left side of your screen, you'll see the posterior view of the scapula. Scapula is otherwise known as the shoulder blade. There's several areas here that we need to talk about. One, if we always take into account when I look at the scapula, where's the spine of the scapula? And there you can distinguish where normal anatomy usually lies or sits. The good thing about these pictures is there is colored in areas on the bones to indicate where the muscle bellies of those individual muscles sit within the bone or on the bone. And so if you follow, these different colors, you'll see posterior deltoid will originate here. Teres minor inserts here. Teres major, infraspinatus originates here. Supraspinatus here. And so this really helps you in kind of visualizing not only the bony anatomy of the scapula, but also where some of the musculature may originate or insert into. If we look in the anterior view, so this is looking at the front side of the scapula. And of course, there's usually ribs and things sitting in front of this. But in isolation, this is what the front side of the scapula looks like. You can see we come up, there's actually some bony projections here in the scapula, one being the coracoid process, which is important for both pec minor and the short head of the biceps brachii attaches into that area. And we also have the acromion. The acromion is one of the most important structures of the shoulder because it's where the articulation occurs with the clavicle, which is also where we have the articulation with the axial skeleton starting. So clavicle attaches to the sternum. This would be the SC joint. We'll get into joints later on, but these are all joints and bony anatomy of the shoulder complex. We think of the shoulder as the glenohumeral joint, meaning the ball and socket joint, which we'll get into in the next slide. But let's not forget about the clavicle or the collarbone and the scapula or the shoulder blade. Those are big time contributors. Actually, it's maybe more so than the glenohumeral joint. Here's what the glenohumeral joint looks like. You see the picture on the left. Again, anterior view. You can see if here we have the scapula kind of in the background of the picture, the coracoid process here. So you see how closely that anatomy is to the actual glenoid. And then you have the acromion here, just to kind of give you guys a little perspective. The clavicle would attach off of here, right? If you go back to that last slide, you will see that. So here's the true glenohumeral joint. And gleno, meaning glenoid, and humeral, meaning humerus. We'd use those two names to reference this joint. So if we can see here, you have the head of the humerus here. You have something called the anatomical neck of the humerus here. And then we have two different projections of bone on the superior shaft of the humerus, one being what's called the greater tubercle and one being called the lesser tubercle. And so these are areas, as you can see by these shaded in areas, of where musculature attaches into these bony ridges or grooves. And so you can just kind of in your mind's eye picture where these muscles attach based on the shaded in areas. Similarly, if we look at the actual shaft of the bone, this kind of works down into the elbow area. As you can see in the bottom portion of this picture, that's where the elbow would articulate. You can see the humeral side of the elbow joint here and here, anterior view, posterior view. But why I like this picture, you can see some of like where the triceps is, the radial groove, which is where the radial nerve kind of transverses through, the triceps and biceps and brachialis insertion on the arm bone. So those all have, outside of the brachialis, those all have articulations, or excuse me, insertion points or origins up into the shoulder complex as well. So what are the joints of the shoulder? You have four main joints of the shoulder complex. You have the AC joint, the SC joint, the GH joint, which we talked about previously, the glenohumeral joint, and then you have what's called the scapulothoracic joint. And so the first three make quite a bit of sense because you have sternoclavicular joint, you have the sternum and the clavicle. Okay, SC, got it. That's where that articulates there. You have the AC joint, acromioclavicular. Okay, that makes sense. Clavicle and acromion articulate here. You have the glenohumeral joint, of course, glenoid and humerus, duh. And then you have the scapulothoracic joint. So the scapulothoracic joint is an interesting joint because it's what we would call a false or floating joint. There's actually no true bony articulation here. What there is kind of a slide and glide rule. The scapula is free moving. It's not bound to the thorax by any sort of ligaments or capsule structures or things like that, which is what these other joints do have. What you don't see in these pictures is that there's ligaments that attach and make sure that the approximation of these joints stay true. The scapulothoracic joint is not the case. So musculature helps, one, keep it in place, and two, helps move it. And it should be very, very mobile. It's the most mobile, mobile bone in the body, in my opinion. Some would argue maybe the humerus is because of the degrees of freedom here, but also the scapula contributes to great humeral movement. So this is not bound by any joint except the SC joint. You can see how this whole complex would be restricted by this pivot point here. So what's the musculature of the shoulder complex? Well, if we look at Da Vinci's picture on the very right of this slide, you can see how just kind of complex and beautiful the shoulder is. This is a picture that he, I think during the 1500s, if I'm not mistaken. But anyways, I've always had a fondness for this picture because what he would do is he would dissect human cadavers and then he would draw pictures of the musculature and stuff that he saw. And actually, Da Vinci probably was much sooner than 1500s, I think. Anyways, there you have it. So you can see just how accurate he was. You can kind of parse through all those different pictures and pull out some of the anatomy. We'll go over some of that as well, of course. So I think of the shoulder musculature in four main categories. As you can see here, we have our primary movers, your rotator cuff muscles, periscapular muscles, and then what we would call accessory muscles. So primary movers include things like your deltoid, your pec major, your lat, your teres major. These are all big, strong musculatures that help you move your arm through space in a general fashion. Then you have more of your stability muscles that, we think of those as your rotator cuff. So supraspinatus, infraspinatus, teres minor, and then subscapularis provides some anterior stability, but also provides internal rotation strength as well. So that subscapularis is kind of a dual muscle. It does provide stability as a rotator cuff muscle, but also can be a primary mover. You can classify it that as well. You have your periscapular muscles. So these are muscles that are around or attach into the scapula, your trapezius, serratus anterior, rhomboids, levator scapulae, teres major. And then we have your accessory muscles. So these are muscles that help with forced coupling. They also help with, stability and maybe non-primary movements of the shoulder complex. So your pec minor, biceps brachii, triceps brachii, coracobrachialis, subclavius, and omohyoid. This is an extra credit question for you, but I want you to try to look up how many muscles attach to the shoulder blade. And this might help you, actually. So this is actually looking at musculature, surface anatomy, and one layer deeper muscular anatomy of the shoulder complex. If we look at the picture on the left, you can see on the left side of the spine, this is going to be more your surface musculature, meaning your very superficial musculature. If we remove a layer of skin and adipose tissue, we'll see underneath your skin is these muscles. So you have your trap, you have your deltoid, you have your lats. These are big, strong, primary moving muscles. If we look at the anterior view of your deltoid again, your trap is here, your pec major is here. Now, if we go to the picture on the right and we remove your pec and your deltoid and all those, you'll see these smaller muscle groups underneath. Here's your pec minor, your coracobrachialis. You can see your subscapularis hiding behind in the back there. Your SCM, your sternocleidomastoid. We won't talk about that enough. That has attachments into the clavicle as well. And then we have on the posterior side, if we look over here, you can see your rhomboids attaching on the medial border of the scapula, your levator scapulae here, your infraspinatus, supraspinatus, teres minor. Those are the other muscles of the rotator cuff, and then your teres major, which is actually not part of the rotator cuff. Technically, the rotator cuff is this collection of these four muscles that create this a compressive stabilizing effect for the glenohumeral joint. And so that would be, again, the supraspinatus, infraspinatus, teres minor, and the subscapularis. We've heard a lot about, and I'm sure you have, of shoulder instability, meaning shoulders dislocating, popping in and out of the socket, subluxing, things like that. Well, this is a picture of the main inert structures that help to prevent shoulder instability or shoulder dislocation. You have the capsulolabral complex, which is the capsule is kind of this netting structure, and the labrum is here. The capsule also is incorporated with ligaments. So you have your superior glenohumeral ligament, middle glenohumeral ligament, antero-inferior glenohumeral ligament, and your posterior-inferior glenohumeral ligament. And if we look at these, you can see these kind of look like finger projections off of the labrum. And you also have your long head of the biceps tendon. And so we look at this, these two pictures are flipped. The picture on the left and the picture on the right are flipped. So this is actually looking at a left shoulder blade. You can see it's clamped in, and it's looking at the surface of the glenoid. This structure is the labrum, and you can see these projections coming off of it. That's going to be, there's no capsule here. This is just the ligaments. They've isolated out the ligaments, as you can see here. This, if we look through the anatomy, this is the long head of the biceps tendon. This is a superior glenohumeral ligament, middle glenohumeral ligament, antero-inferior glenohumeral ligament, and posterior-inferior glenohumeral ligament. And so this is has this kind of finger-like grasping. This is how I think about it, like grasping to keep the ball in the socket, right? This is looking at the ball side of the situation. You can see where these attach into. You also have these muscular attachments to reinforce the stability of the glenohumeral joint. This is another way to think about this. We think about the glenoid and the head of the humerus almost like a clock face. That's to allow us to talk about where injuries may occur. So you have, 12 o'clock all the way up to 11 o'clock, or you can go around clockwise here. And a lot of these injuries happen in this 3 to 6 o'clock range. And so this, as we'll talk about later, based on kinematics of the shoulder, it's important to know where injuries occur within the glenoid and or the capsulolabral complex, because then that might change our exercise prescription and rehabilitation so that we don't engage or irritate the tissues that are torn. And so the kinematics and arthrokinematics, if you will, of the shoulder are important to understand so that you don't engage those areas too soon in the rehabilitation process. Quickly here, we'll go over the neurovascular anatomy of the shoulder complex. This is quite complex, especially for an intern, especially for even a PT student. As you're getting out and working with more patients, this becomes much more necessary to know. But, from the actual picture here, you can see how complex our anatomy is in terms of both nerves, arteries, veins, and kind of the highways, if you will, that they pass through. The big thing that I want you to understand here is you have right below the collarbone, exiting the neck, you have what's called the brachial plexus. And this is accompanied by not only the nervous system tissue that you see here, but also the subclavian artery, subclavian vein, both transverse down the arm, and they branch off and you give blood flow to your arm all the way down to your hand. Likewise, your nerve travels all the way down. There's some different things that can happen here that these tissues get injured. You can have a stinger, which would be a direct blow to this area. You can have a stretch injury where your arm gets taken, forcefully through a range of motion. These nerves get stretched. You can have a blood clot, which can injure this area. You can have what's called thoracic outlet syndrome, which somewhere along the chain here, the nerve, artery, or vein is getting compressed and pinched off, if you will. So there's a lot of things to consider with the neurovascular anatomy of the shoulder, but this is an overview of that. So what's the basic kinesiology of the shoulder complex? Well, osteokinematics is a term that describes bone movements of the shoulder. And so these are your big global movements that you can see with your eyes. And so what I've put on here is pictures on the very left, the shoulder blade. So the shoulder blade can go through several moments of motion. And so we're talking about internal and external rotation. So some would call that protraction and retraction of the shoulder, right? You can do that with your own shoulder blade. You can also have upward and downward rotation. So as you lift your arm overhead, your shoulder blade will tilt up. And as you bring your arm down, the shoulder blade will tilt down. And then you can have what's called posterior and anterior tipping. So anterior tipping would occur here, and posterior tipping would occur here. And we think about the tipping by this inferior angle of the shoulder blade so that the base, or this part of the shoulder blade, if it tips backwards, we call that anterior tipping, right? The face of this is tipping forward and the face of this is now tipping backwards. So that's what this picture is describing with these red arrows here at the bottom. Likewise, we move into the clavicle or the collarbone. You have a couple different motions you can have here. You can have elevation, right? If you think about collarbone here, you can have elevation, you can have depression, you can have protraction, right? It levers forward, retraction, it levers backwards, and then you can have spin, right? Spin of the shoulder blade. So if you rotate forward too much, right, you can imagine how that collarbone will rotate forward, rotate backwards. And if we look at the actual glenohumeral joint, there's 6 degrees of freedom of movement here. Just on this basis, you can have combined movements as well. It gives you more freedom of movement, but you have internal and external rotation of the shoulder, which would look like internal, external rotation. You have abduction and adduction, and you have flexion and extension of the shoulder. And so you can have combined movements like horizontal abduction with external rotation, with elevation, right? So you can combine these movements as well. Which gives it quite a bit of freedom of movement and also makes the rehabilitation complex a little more complex. The rehabilitation is a little more complex because of that. So what are arthrokinematics? Arthrokinematics is actually the movements that are occurring within the joint, and arthro means joint, right? So what are the joint mechanics? We know what the bone looks like it's doing, but how about the actual surfaces of the bone? And so if you look at the picture on the left, this is kind of a PT school concept. So if I'm losing you here, then that's okay. We'll talk about this in person if you need to. All right. But this is where it's important to know what the ball and socket are doing in relation to each other during different arm movements. And so again, if you had a labral repair and the anterior inferior portion of your labrum is injured, we want to make sure that the positions we're putting your arm in are not engaging that area until the proper time. And so if you look at the picture on the left here, as you go to elevate your arm, what's happening is here's the socket, here's the ball, your arm is rotating up. As your arm levers and rotates up, the ball actually slides inferior in the joint. So what you get is this superior roll of the joint, but an inferior slide or glide. If you rotate your arm, let's say external rotation, you get an anterior roll and a posterior roll, right? It's rolling backwards, and an anterior glide. And so this, again, is a concept that's a little tough to understand, especially in a basic anatomy review lecture like this. So we can talk about this more in person. I can nail this down if you need to. You can see these are the 2 situations I talk about. Raising your arm up, you can see it rolls superior, but it glides inferior. And then, of course, on the right, you can see here's your subscapularis, here's your infraspinatus. That's your internal rotation, external rotation, force couple. If you're externally rotating your arm, it's going to roll backwards, it's going to slide forward. So you can imagine if you have a labral repair here, we might want to avoid external rotation early on to a certain degree so we don't engage the structures of the labrum here. So that's kind of the general concept of why we need to know this information. So let's get into what's called scapulohumeral rhythm. Scapulohumeral rhythm, if we break down those words, the rhythm between your scapula and your humerus to get your arm up overhead. And so there's different contributions of range of motion from your shoulder blade and from your arm bone that helps you get fully 180 degrees overhead. And so each one of these pieces of anatomy helps you do that. So what I want you to understand here is that when you go to lift your arm up overhead, this is not true 180 degrees from your arm bone. The shoulder blade actually contributes by upwardly rotating about 60 degrees to provide a stable base of support for your humerus to sit on. So you have 60 degrees of scapulothoracic joint upward rotation, and you have 120 degrees of glenohumeral joint abduction, which gives you a total of 180 degrees of motion. And so you can look at the picture here on the right that gives you a little better picture there. How do we get overhead from a muscular standpoint? Well, there's 3 big muscles that help you do that. You call it 4. You need your deltoid. Your deltoid is your primary mover for shoulder elevation, however, or humeral elevation, but you do need your upper trap, your lower trap, and your serratus anterior to work in unison to get your arm up overhead as well. So we need to get a muscle that helps with an upward rotation, a posterior tilting, and an elevation. And so those 3 forced couples together will help you get overhead. And so I want to thank you guys for your time. This has been very helpful for me to review this as well and to try to put this topic into words instead of just trying to understanding it from the PT perspective. So I'd love to talk about this with you guys and nail down some of these concepts a little further if needed. Thank you guys. And again, appreciate your time.